Good afternoon, everyone, and welcome back to the Lusaka Apex Medical University Virtual Clinical Educational Grand Round. I'm your host, Ms. Shinondo, as part of Corporate Communications. Today's topic is enteric fever, otherwise known as typhoid fever. This is a bacteria spread through Salmonella. Let me pronounce this correctly. This is caused by a bacterial infection caused by Salmonella enterica serotype tri, or 5. It's commonly spread through contaminated food, water, and similar circumstances. I would like to acknowledge the presence of our professorial team. We have Professor Njelasani, Professor Lambert, Professor Mudenda, Professor Mwava, as well as Professor Mulenga, Professor Mwansa, Professor Kasola, Professor Viemba, Professor Kumar, as well as Professor Emaus, Professor Gilani, and others. Once again, these presentations are a part of skill set building within our students. Here at LAMO, we believe in building a strong foundation in our students, building skill sets that will take them through their professional lives, and as well as complement them within their personal spheres. Skills such as long case presentation, public speaking, self-presentation, as well as critical thinking and webinar etiquette. Also, our students who are presenting, for our students, I need our members in the audience to know that you too also benefit from this. This is where you get comfortable with online etiquette. You are acquainted with Zoom, whatever platform we're using, and please, please, please take advantage of this to learn how to ask questions. There are no wrong questions. If anything, your questions open the doors to more information being shared, as there will be a broader discussion had. Without any further ado, I would like to invite our moderator, Dr. Mpisa, to briefly introduce the topic and begin the presentation. Dr. Mpisa, the floor is yours.
Oh, thank you so much, Madam Chinondo. Welcome everyone to our grand round. My name is Dr. Sidney Mpisa, HOD Internal Medicine. Today again, we bring you your team, the medical students. It's their work as is to just guide them as they present on enteric fever, which is a very common infection. And why we like it, it is a multidisciplinary infection where we involve the surgeons, we involve the physicians, because it can present with perforations and acute abdomens, where we then call the surgeons. It can complicate pregnancies. So today we decided to present on that and to leave the floor to the presenters. Thank you, Madam Shinad.
Thank you so much. Good afternoon, ladies and gentlemen. My name is Malwa Hamugari, a fifth-year medical student at Apex Medical University from the Faculty of Surgery and Medicine. Today, we're going to present on enteric fever, and I'm going to be running you through the history part of this presentation. I'm presenting I am 49-year-old male who is a businessman and is married. He's Christian by religion, and he resides in Enteric. He was admitted on the 26th of March 2025 and returned on the 27th of March 2027. The informant was the patient, and he was a referral from China clinic. His presenting complaints were headache 5 days and abdominal pain for 2 days. History of presenting complaints. The patient was well until 3 weeks ago when he experienced a headache, which was of sudden onset, generalized, dull in nature, and non-radiating with no exacerbating factors, and relieved by rest and taking paracetamol. The headache resolved but resurfaced 5 days prior to admission, which was now associated with fever, abdominal pain, and joint weakness. Fever was accompanied by chills and sweating. It was described to be on and off, and it would worsen at night and would cause him to sweat. The fever was, he experienced abdominal pain, which was felt on the lower abdomen, of birth onset, and with character in non-radiating. It was triggered whenever he wanted to use the toilet, and it was renewed whenever he was not doing anything. The patient could not grade the severity of pain. He had about 4 to 5 episodes of diarrhea in a day, which was described to initially be yellow in color. Then a day later, he noticed that it contained spots of blood. He added that he felt to pass through for a day and he had no appetite. The patient also had multiple episodes of vomiting whenever he attempted to eat for the past 3 days. The vomitus was brownish in color and he could not quantify. His wife noticed that his eyes were yellowish, and this was after taking the herbal medication. This prompted them to visit the nearest clinic. The patient added that he was also unable to pass urine for the past 3 days. There was no bladder fullness, however, and no history of painful urination and blood in urine or change in color. On review of systems, GIT, GUT, central nervous system, musculoskeletal system as reviewed in the history of presenting organs. Respiratory system, there was no cough, no wheezing, no hemoptysis, dyspnea, or chest pain. CVS, no or chest pains, no easy fatigability, and no paroxysmal nocturnal dyspnea. On past medical history, there is no history of similar illness, no history of diabetes, no history of epilepsy, no history of asthma, no history of TB or exposure to TB, no history of hypertension or sickle cell disease. The IRBD status is unknown. On past surgical history, there are no past surgeries or operations. On drug history, past drug history is coartem, doxycycline, and paracetamol. And it was noted that these were self-prescribed as the patients took them prior to the first symptoms before he went to the hospital. There was also history of using of herbal medication, and patients stated that she took some pounded cassava leaves liquid, which was uncooked, when the symptoms first began. Current drug history was on Ringer's lactate and normal saline. There was no allergies noted. On family history, there is no family history of diabetes, no history of epilepsy, no history of asthma, no history of TB or hypertension or sickle cell disease. There is also no history of similar presentation in the family. On socioeconomic history, the patient takes alcohol and he drinks on weekends. He takes black label and castle. The patient could not quantify how much he drinks. He does not smoke, however, and lives in a well-ventilated house and uses a flushable toilet. He does not live near water bodies and drinks tap water. There is no history of travel. There is history of travel as if he's a businessman, and he travels within and outside Lusaka. Summary: I'm presenting. I am male 49, a businessman with history of frequent travel, previously known well with unknown RB status, who presented with a 5-day history of headache with associated joint weakness, and a 2-day abdominal pain, which was associated with vomiting and diarrhea, but that had streaks of blood as well as intermittent fever. He later developed anuria for 3 days, yellowing of eyes, and admitted to taking herbal medication. He denied any dysuria or bladder fullness. Diagnosis: enteric fever with acute kidney injury. On differentials, we have number 1, malaria with AKI. Number 2, drug-induced liver injury. Number 3, acute viral hepatitis. Number 4, sepsis. I'm now going to invite my colleague to the podium. Thank you.
Very much. Good afternoon, ladies and gentlemen. My name is Daniel Siwana. I'm going to walk you through the physical examination of the patient with enteric fever. And we begin with the vital signs. Blood pressure, systolic 184, diastolic 82 millimeters of mercury, pulse 57 beats per minute, respiratory rates, it was 20 breaths per minute. The temperature was 38.7 degrees centigrade, and the oxygen saturation was 98% on room air. The general examination: from the foot end of the bed, the patient was very supine in bed, and he appeared stable. He was well oriented to time, place, and patient, and in good nutritional status. There was not in obvious respiratory distress. There was visible jaundice. Then he had a cannula in situ with fluids running on his right hand. He also had the urinary catheter valve in situ with 100 ml of dark urine. Then on closer inspection, he was febrile to touch. He had no palmar but had palmar jaundice. There was no leukonychia, no pyronychia, there was no palmar edema, and no fluid handling. There was no asterosis, there was no turbulence contractures, no peripheral cyanosis, no splinter hemorrhages. Then the capillary refill time was less than 3 seconds. The rate of pulse was 57 beats per minute. There was no lymphadenopathy and no loss of hair in the armpit. There was no conjunctival bulb. There was no cyanosis. Scleral jaundice was present. There was no xanthelisma, no parotid enlargement, and there was no ambulatory keratitis, no central cyanosis, and there was no bursitis, no thrush or any other oral ulcers. Then there was no neck stiffness, because you know that the typhoid also can complicate with meningitis. And then there was no another disorder. Then systemic examination. We begin with the gastrointestinal system, the abdomen. On inspection, there were no scars, no distension or visible masses. There were no striae or no caput medusa and no rose spots. On palpation, the abdomen was soft. There was no organomegaly, no renal angle tenderness, and then on percussion, it was tympanic, there was no shifting downwards, and then there were no bowel sounds. Respiratory system, on inspection, there were no scars, there were no muscles, there were no deformities. The chest wall was symmetrical, there was no spider nearby, and no gynecomastia. Then there were traditional tattoos that were noted. On palpation, the chest expansion was symmetrical. Then the trachea was centrally located. Ductal vocal corridors was equal bilaterally. Then the apex bit was palpable in the field intercostal space mid-clavicular line. The percussion note was no through the hand ribs, and there was no down lips for in and resonance. On auscultation, there were vesicular sounds bilaterally. Then there was no air entry in all the new fields. There were no any updated sounds. And then the vocal resonance was normal. The cardiovascular system, the apex bit as alluded to, it was found in the field intercostal space, mid-clavicular line, and then on auscultation, the S1 and S2 were regular and normal and were not heart murmurs. The central nervous system, the mental status, the patient was alert, oriented in time, place, and person. When the language was fluent and coherent, all the cranial nerves were examined and they were found to be intact. In the motor function, on inspection, there was no muscle wasting, there were no fasciculations, there were no tremors. Then the muscle tone in both the upper and lower limbs, it was normal. The muscle power, it was 5 out of 5 in all the 4 limbs. Then the reflexes, they were all normal, both the biceps, the triceps, the knee, the Parkinson side, as well as the arm reflex, they were all normal. In the sensory function, there was no perception of light, the pain, touch, as well as temperature. Then the continuation and gait, the finger to nose test was normal. The heel to shin test was as well normal. So the continuation was intact. Then the gait was normal and steady as well. Musculoskeletal system, there were no visible deformities, there were no rashes, no swelling or muscle wasting, there were no skin changes and no tenderness over the joints. In the bedside investigation, we did the urinalysis, and the findings were as follows. The leukocytes were 2 plus, nitrates were positive, urobilinogen was negative, the proteins were trace, specific gravity was 1.415, the ketones were negative, bilirubin was 2 plus, glucose was negative, and then the color of the urine was dark orange. The urine output was assessed and it was found to be 100 mils in 24 hours. Summary, I examined an adult male with no obvious signs of respiratory distress. However, he was febrile to touch and was noted to have jaundice as well as bradycardia. The urinalysis had positive findings of moderate bilirubin, nitrates as well as moderate leukocytes, and was dark orange in color. He had reduced urine output of 100 mils in 24 hours. Diagnosis, after examination, we still maintained the enteric fever with acute kidney injury, but with regards to the differential diagnosis, we had to make some adjustments. So the first one is malaria with acute kidney injury. The second one is viral hepatitis. Then the third one is the pyelonephritis. So this marks the end of my presentation. So I'm going to invite my colleague to come over to the podium.
Good afternoon. My name is Tipos Ekelechi, 7th-year medical student at Apex Medical University in the Faculty of Medicine and Surgery, and I'll be taking you through the investigations. So we're going to begin the investigations with the tests that we ordered for our patient, starting with the urea electrolytes and creatinine. So in soldier, it was hyponatremia, which was noted, the level of 121 millimoles per liter. With potassium, there was hypokalemia. You can see there was also hypochloremia, and with urea, was uremia noted, the level of 19.58 millimoles per liter. So the urea levels were quite high. Creatinine was also elevated with a level of 890.4 micromoles per liter. Moving on to the C-reactive protein, a quantitative CRP was done and CRP was elevated. The full blood count, platelets, and differential count were also taken. So the white cell count was high. The red cell count, hemoglobin, and HCT were all low. The MCH and MCHC were high. The mean platelet volume was high. The platelet distribution we did was low. Moving on, we're going to now look at the differential count. So under the differential count, there was neutrophilia and monocytes were also high. So neutrophils were high and monocytes were high. The malaria parasite slide was also taken and it was negative, it was non-reactive. Hepatitis C antibodies were tested, came out negative. Hepatitis B surface antigen was non-reactive. Lastly, we did a cross-match for the patient, and his ABO group was A, and he was anti-D positive. There was also a hepatitis A IgM, which was done and was negative. Then the last tests which were done were the liver function tests. So under the liver function test, bilirubin, the direct bilirubin was elevated at 116 millimoles per liter. Alkaline phosphatase was at 217. It was high also. ALT was elevated as well, but the albumin was low. So now move on to the test that we will do ideally for our patients. So we divided our investigations into diagnostic and supportive investigations. So starting with the diagnostic investigations, start with the blood culture. So the blood culture is sensitive for diagnosing enteric fever, especially in the first week. Then after the second week, when salmonella has spread to stool and urine, we can do a stool culture and a urine culture. Then you can also do the bone marrow culture, which is a gold standard. You can do this one even after the patient has started antibiotic treatment. So the white blood test, it's limited because it's not too specific. Even individuals who had enteric fever in the past and have resolved can still give a positive white blood test. So it can give a false positive. Do a serum creatinine and blood urea nitrogen, which is usually elevated in AKI. Can also do a fraction excretion of sodium, which differentiates pre-renal and intrinsic versus intrinsic causes of AKI. So if the fraction of excretion of sodium is less than 1%, we can suspect a pre-renal cause rather than an intrinsic. And there's also a renal ultrasound that can be done to rule out obstruction in the renal biopsy. The intrinsic cause is suspected and an etiology is unclear. So we'll now move on to the supportive investigations, starting with a full blood count. So the full blood count, what we can find is leukopenia, anemia, and thrombocytopenia. Though if there is intestinal perforation, even leukocytosis can be seen on the full blood count in enteric. Liver function tests, they can be a mild transaminitis and hyperbilirubinemia, just as we have seen from the tests that were done in our patients. The ALT, AST were elevated, as well as bilirubin levels increased. We also do a C-reactive protein and ESR, which can be elevated in active infection. Abdominal ultrasound under the imaging can show hepatosplenomegaly, hepatosplenomegaly, or mesenteric lymphadenopathy. Okay. The ECG, you can just look at the ECG to detect the effects of hypokalemia, such as the pitch T waves and arrhythmias. And lastly, we do arterial blood gases showing metabolic acidosis in AKI. That marks the end of the investigations. I will now call upon my colleague to the podium. Thank you.
Good afternoon, ladies and gentlemen. I'm Emmanuel Mulenga, second-year medical student, Faculty of Medicine here at Lusaka Apex University. And I'm going to be doing the management and literature review part of our presentation this afternoon. With the management, throughout the time we were with the patient was only given intravenous fluids. So ideally, the management that would be done in the patient with enteric fever, the patient were presenting on the day to be discussed under the literature review. So, enteric fever is an acute systemic illness characterized by fever, headache, and abdominal distension. And then it is also worth mentioning that the World Health Organization estimates a global enteric fever disease burden at 11 to 20 million annually. The cause of enteric fever is Salmonella enterica typhi and paratyphi A, B, and C. And then just a short description of this type of bacteria. These are the family of Enterobacteriaceae, gram-negative rod. They have a flagella that help them move around and are facultatively anaerobic, meaning they are able to survive with or without oxygen. Going through the pathophysiology, enteric fever is passed on from person to person through fecal-oral route. So infected individuals ingest bacteria through contaminated food or water, and like most other foodborne illnesses, improper food handling and poor hygiene is often the blame. After ingestion, the ingested bacilli invades a small intestinal mucosa. The bacilli now moves to the small intestines in the ileum, and it does this after having survived the stomach acidity environment. From there, it is then taken up by macrophages and transported to the regional lymph nodes. So it is phagocytosed and it travels through the lymphatics and is transported to the regional lymph nodes, where when it reaches there, it then multiplies intracellularly, especially in the pairs patches. After that, it then interacts with the enterocytes and M cells, the ileal pairs patches. And during this, it is also worth mentioning that the incubation period is from 3 to 21 days. It interacts with the M cells and enterocytes, leading to intestinal inflammation and diarrhea in some patients. The bacteria then moves and causes bacteremia. This is the bacteremia phase now, the onset of typhoid fever. In the bacteremia phase, we tend to have symptoms now like fever, malaise, and abdominal discomfort. After that, the bacteria will now move to various organs that include the gallbladder, the biliary system, and the tissue of the bowel, and multiply in high amounts, contributing to carrier states also. It is then passed into the intestinal tract and passed outside the body through, and the cycle continues just like that. Worth mentioning also are the virulence factors, the VI antigen, which is the VI capsule that inhibits phagocytosis, and the toxin that's produced exclusively when the Salmonella typhi is intracellular. So the endotoxin induces cell cycle arrest, and in this way, it kills the host DNA. Worth mentioning also is that the greater the infectious dose, the more infectious the bacteria becomes, and the shorter the incubation period. But also, just small amounts of this bacteria can cause illness in various individuals that include patients on proton pump inhibitors, immunosuppressed patients, as well as patients that have aclohydria, which is low absent stomach acid, because the stomach acid reduces the disease causing of this bacteria. Moving on to the clinical presentation, this will be divided in 2 weeks, first, second, and third week. Let's start with the first week. We notice that there is malaise, headache, cough, sore throat in the prodromal stage. So these symptoms come about due to systemic response and immune activation due to the bacteria. We also notice that in the first week we have step ladder fever, which starts as low grade but progressively rises over the days. Abdominal pain as well when the bacteria multiply in the lymphoid tissue. This is due to mesenteric lymphadenopathy. That's what will bring about the abdominal pain. And then some patients will also have constipation with diarrhea. That's due to intestinal dysfunction due to inflammation of the mucosa of the intestines. Moving on to the second week, we notice that we have hepatosplenomegaly on that diagram. This is when the bacteria, there was bacteria, the bacteria moved to various parts of the body. When they invaded the liver and the spleen, they cause cell infiltration and subsequent enlargement of these organs. In the second week, we also notice related bradycardia, otherwise also known as the packet sign. How does it come about? The endotoxins affect the autonomic regulation, hence leading to a slower heart rate than is actually expected for the fever that these patients have. Moving on to the third week, we notice that there is apathy, toxemia, delirium, and coma. So this comes about due to various reasons, and these include severe systemic infection and prolonged inflammation. And also, these patients tend to vomit, diarrhea as well. So there is also a part that dehydration may play in this. It may lead to electrolyte imbalances that will also contribute to the central nervous system dysfunction, hence causing these changes. This is also called the typhoid state. And in the third week, diarrhea is now even more pronounced. So the rose spots, this is just a picture depicting rose spots that we tend to see in the second week. And then we also wanted to talk about Typhoid Mary. So Typhoid Mary was just a nickname given to Mary Malone, who was an Irish woman who was working as a cook in the United States of America. So what was happening was that in the various households where she was working, a lot of individuals were falling ill, were ending up with Enteric. And then at the beginning, they didn't know where it was coming from. But then when she was discovered to see that she was a chronic carrier state patient, despite being symptomatic, she kept on passing on the illness to other people. So this takes place when the enteric fever is in the gallbladder. So these patients are carriers in that they have the salmonella typhi chronically in the gallbladder, but they don't even show symptoms themselves. They don't show any signs of illness with enteric fever, but they keep on passing through the bacteria through the stool. We can now move on to the investigations. They were largely explained by the previous presenter, so I'll just give some short notes on a few things. With the diagnostic, the blood culture, which is done, bone marrow culture is also done, and is, as we mentioned, more sensitive. Why do we say so? Because bacteria salmonella typhi can survive and multiply with macrophages in the bone marrow, even after clearing this illness from the blood. So the blood test would show negative, but when you actually do the bone marrow culture now, you'll find that there's a positive result because the bone marrow part is less affected by prior antibiotics. Stool culture and urinalysis, urine culture is also done. Rose spot biopsy is also done. And the wider test, which is also done, but as he earlier mentioned, it's not too much relied on because it can give a false positive result. Even in patients who just had a recent vaccination, for instance, or enteric fever that was already treated. Moving on to the supportive, the full blood count will show leukopenia, thrombocytopenia as well, and leukocytosis. So most of these are due to salmonella invading the reticuloendothelial system, leading to suppression of hematopoiesis. That's what will bring about most of the blood test changes that we see. And then anemia is also very common. As we saw in our patient's HB hemoglobin was 8.7 grams per deciliter. So this could be as a result of the same altering of the hematopoiesis process, or even just the gastrointestinal bleeding that we tend to see in some patients with enteric fever. That may lead to anemia. With the liver function tests, we often see transaminitis, which is just elevated levels of transaminase enzymes that are alanine aminotransferase and aspartate aminotransferase. What will cause transaminitis? It's usually due to just direct invasion also of the liver tissue by the bacteria. Inflammatory cytokines may also play a role, as well as endotoxin-mediated damage. Urea and electrolytes, we tend to see hyponatremia and hypokalemia also. As we also saw in our patient, with the results that were done from the hospital that were presented, our patient presented with a mild hypokalemia and hyponatremia. It is very common in patients with enteric fever. And these changes come about due to various causes that include also gastrointestinal losses through dehydration, diarrhea, that would cause that, also due to syndrome of inappropriate antidiuretic hormone secretion. And the polymerase chain reaction will also be done. Enzyme-linked immunosorbent assay will also be done. But I also wanted to touch on the alanine aminotransferase stroke lactate dehydrogenase ratio. When do we usually tend to doing this investigation? So there are times when we might be questioning ourselves, are we dealing with enteric fever or hepatitis? So this test would help us differentiate between the two. How does it do that? Because it helps differentiate in that when there's a ratio of 9:1, it favors more of hepatitis because enteric fever tends to have a lower alanine aminotransferase compared to lactate dehydrogenase. So when the ratio is 9:1, then we're dealing with hepatitis. That will at least guide us to a different diagnosis. Imaging like ultrasound and CT scan, MRI will just come in when we're now trying to look at the various complications that may occur. So after the investigations, we can now talk about the management. So like I earlier mentioned, our patient was only on normal saline, 500 mils at the time at which we saw the patient. How do we manage enteric fever? We first have to stabilize the patient. We have to make sure that we assess the airway and make sure that the patient is breathing just well. Make sure that there are no secretions or anything obstructing the airways. Because patients with enteric fever also end up with complications like encephalopathy, and that will predispose the patient highly to obstruction of the airways through secretions. Breathing also, we'll have to assess that the patient is breathing just well, check the respiratory rate, circulation, make sure that there is adequate circulation in the patient, check for the pulse, color, skin, temperature, capillary fill time, and then also gain IV access with 2 large cannula. We'll have to draw blood for tests and catheterize the patients to monitor urine output. And also remember that vomiting and diarrhea that the patient had throughout this presentation may have led to dehydration. So we have to put the patient also on fluids, like normal saline, for instance. And then the mainstay therapy for enteric fever, as we can see from here, are antibiotics. So we start from here. So we're going to divide the antibiotics into empirical treatment, fully susceptible, multi-drug resistant, and nalidixic acid resistant. When do we use empirical treatment? When the specific organism has not yet been identified and the sensitivities are not yet known. We tend to use empirical treatment where we give the patient ceftriaxone or azithromycin. Fully susceptible patients, on the other hand, are patients that are sensitive to strains of Salmonella to the first line antibiotics that we tend to use. So these are not resistant. We tend to give them ciprofloxacin, amoxicillin, chloramphenicol, trimethoprim, sulfur, methoxazole. Ciprofloxacin 500 milligrams twice the oral, or 400 milligrams. And moving on to the multi-drug resistance, these are strains that are resistant to all the traditional first-line drugs. But we can give them ciprofloxacin, ceftriaxone, azithromycin as well. Nalidixic acid-resistant patients can be given ceftriaxone, azithromycin, and also a high-dose ciprofloxacin. So nalidixic acid, just a comment, was usually used as a quinolone antibiotic for gram-negative organisms. Hence, the reason why it's also used sometimes in enteric field. Having done the management, we can dive into prevention first. How would we prevent enteric fever? Practicing good personal hygiene, hand washing, awareness, education of communities about how it is spread and how it can be prevented, and also vaccines. And as you can see from here, these are some of the complications that patients may end up with: intestinal perforation, which can be as a result of necrosis of the pairs patches in the ileum, which leads to ulceration and eventual perforation. Patients would also end up with intestinal hemorrhage as a result of the erosion of blood vessels in the intestinal mucosa. So you can even end up seeing blood in stool. Encephalopathy is another complication that would come from this, and it may be as a result of neuroinflammatory and ulcerative destruction when the bacteria causes through the toxin the blood brain barrier, or even metabolic derangements. In encephalitis, we can see confusion, delirium as well. Hepatitis as a result of direct bacterial involvement and invasion, and also acute kidney injury as in the patient that the case is about today, which can be through prerenal, when there's too much fluids lost in the body through diarrhea, dehydration. So the patient now ends up hypovolemic, no blood going to the kidneys. The patient ends up with a lower than normal glomerular filtration rate, hence acute kidney injury. But also would be due to sepsis or the bacteremia causing acute tubular necrosis. So this is where we end our case presentation this afternoon on enteric fever. Yes.
Well done, presenters. Job well done. Please, a round of applause for yourself. Dr. Mpisa, any summary for this presentation?
Thank you so much, Madam Shinondo. So well done, team. I'm proud and I'm impressed. That was a well thought case in the discussion. I liked how you didn't look. I liked how you built on the slides, the few information which was on the slides, and how you built. So just to summarize, enteric fever is very common in our setup. It's a systemic disease, as emphasized. Please remember that in adults, it can present just as a febrile illness. Then in children, that's why mainly they come with a diarrhea, which was described in the history as a pea soup diarrhea. People who are on antacids, like you mentioned, guys, that if you reduce the acidity in the stomach, that can predispose again to enteric fever because the bacteria can survive better because the acidity would have been neutralized. There's also a role for cholecystectomy. I liked it when you mentioned typhoid Mary because she was a chronic carrier, and these patients they have the typhoid hiding in the gallbladder. So there's a role of prophylactic cholecystectomy. It was part of the management of the chronic carriers because the antibiotics might not reach the biliary system. If you remove that gallbladder, you are dealing with the chronic issue. So thank you so much, Tim. Now I'll hand over to Ms. Chinondo to invite questions. Thank you.
Excellent. Thank you, Dr. Mpisa. Now, before we begin question and answer session, I would like to do a quick roll call. Can those who are listening in from the various locations, you can just let us know in the chat. You can simply indicate whether it's any of our Chalala campuses, whether you're listening from your placement sites, which placement site is it? Are you listening from Chongwe, Chipata, wherever it is? Please feel free to let us know. Those of you who are listening from outside of the country, feel free to let us know, country and your city. For example, our presenters are presenting from our main Chalala campus. Okay, so we have Petronella. She's tuned in from Kawe Central Hospital. You're most welcome. We also have our former Dean of Health Sciences, Dr. Kondo. You are most welcome. He's from Gaborone, Botswana. You are most welcome. Thank you for tuning in, Dr. Kondoe. Actually, please let me amend. He is no longer Dr. Kondoe. He is Professor Kondoe. Congratulations. We also have Mwalimu from Kabwe site. Welcome. We have Trevor, UTH. We have Natandala, Levi Monawasa, University Hospital. Excellent. Welcome. We have Rosalia from, please give me a moment. I'm trying to catch up with all of your messages. From UTH. Welcome, welcome. We also have Walia. She's from, well, he or she is from Levi Monawasa Hospital. We have another from Levi Hospital, that is Hamalala, as well as Leah Mu and Mason. Who else do we have? We have Helen and Moses from UTH, Abraham, UTH. We have Thomas, UTH as well. No, my apologies, Levi Teaching Hospital. We have Fitness, Kawe, you're most welcome. We have Kekelwa, UTH, Clive, Levi Teaching Hospital, excellent. Right. This was great. This was great. Now, we can now move on into our question and answer session. How this usually works, you can either ask your question by raising your hand and the floor will be given to you. You're free to ask your questions. This is a chance for you to speak directly with our presenters, moderator, and so on. Or you can simply write your question, observation, or comment in the chat, and it will be read out for you. So the floor is open. Question and answer session is here. while people are typing in their question. Actually, we have a hand up. This is from our own. This is a Lama question. School of Medicine, please. The floor is yours.
Wanted to find out, is there a role of imapinem in a case where we have drug-resistant kind of treatment? For example, if it has gone to the CNS, I understand enteric fever can also affect the CNS. So is there a role for imapinem in a situation where we have that?
Is there a role for maybe now?
Kindly repeat the question.
In a case where we have CNS infection and with enteric fever, and the drugs are not working. For example, you try your first lines, your second lines. Do you think we can also use imapinem in such a situation, or what's the alternative we can use if our first line and second line don't work?
Okay, so for drug-resistant strains of Salmonella, we usually just increase the doses of the already used antibiotics. If you're following the management, there was the extremely drug-resistant strains that were treated with ciprofloxacin, azithromycin, and it was just an increased dose. So I haven't come across imapinem as one of the treatment modules, but for the drug-resistant ones, it's what we follow. Thank you.
Okay, thank you. Maybe I can come in to help. So thank you for the question on imapinem. Yes, so we rarely use it, but it has a role in XDR typhoid. We can use it with or without azithromycin, but it can be used. The only challenge, like in our patient, imapinem is nephrotoxic and our patient had renal impairment, so it won't be the drug of choice, but it has a role. Thank you.
Wonderful. Right? Do we have any more questions? Any observations? Okay. So, this was Mwape Usenga, listening from UTH. It says thank you. Okay. Any other questions? Please feel free. This is an open platform. We are all here to learn.
Good afternoon. I've got a question.
Please.
First of all, I want to, if I could be taken back to the summary of the history, I want to ask on the history and the examination. Okay, so maybe just maybe from here, I'll begin with this one. From the history of presenting complaints, I would like to find out what risk factors were pointing to enteric fever. What risk factors could we point to that could be conclusive that we could be dealing with enteric fever? And then on the summary, I want to take me to the summary. Okay, so on the summary also, I appreciate the fact that you gave us some positives, important positives, and some important negatives, but as well, I would like to find out why you left out, again, the important risk factors, pointing out to this aspect of enteric fever. And then on the social history, I heard you mention something to do with water, that they drink water from the tap. I don't know if I just did get you right. You did not mention what they do with this water, whether they boil it or they add chlorine. But you mentioned the fact that they drink water from the tap. I think for history, I would need that response, and then on examination as well. Just rush me to abdominal examination. Okay, so on examination, I would like to find out just on the summary. Just I've seen what I wanted to see just on the summary. Okay. So on the summary also, I want to find out some important negatives that should have come out on the summary. Of course, well elaborated on the important positives. I'm wondering why some important negatives, such as the rosy spots that you had earlier alluded that they were not there. Why they didn't come out on the important negatives in summary? Thank you so much.
Starting with the risk factors from the history of presenting complaints. What pointed us to enteric fever was just the pattern of the illness and the presentations that the patient came with. We didn't really pick any risk factor from the history of illness.
Yeah, I think in addition to what the colleagues just said, when we look at our patients, he gave us that history of being a businessman and he travels fluently. So we know to know what we know that typhoid actually is a waterborne disease. It's transmitted through contaminated food or water. So we need to know actually when we do one of these travels, if actually it's exposed to contaminated foods or contaminated water. So probably you might have contracted this typhoid fever chronic during one of those travels. That's number one. The number two, with respect to the examination, when you look at the typhoid fever, the period in which the patient presented, the patient period was between 3 and 21 days. So that's when the disease actually like established in the GI. So the GI region, the proliferation of bacteria within the virus patches, and it will induce inflammatory reactions. So that process, this will actually, the will actually promote the immune response and actually to see symptoms such as fever and abdominal pains, headache, and the like. And when you look at the period in which the patient presented, the patient must have presented during the first degree of that infection because the response actually we can only see them in the second week of infection after this hematopoietic spread of the disease. So it's the case with the hepatomegaly. That's why actually we don't appreciate the hepatomegaly because it can only be appreciated either in the second week or the third week of infection. So at that time, there was no hematogenous spread of the typhoid fever. Thank you.
And to add on the question you asked about tap water, you mentioned to say that the water it's cancer water and they don't boil it or put chlorine in. Yes, thank you.
Just another addition, and so the diagnosis that we ended up with was collective. Another thing that's worth mentioning is the biphasic progression of these clinical features from the history of presenting complaints. So the patient first presented with headache, that resolved, and then it returned with other features now, like abdominal pain, which is characteristic of enteric fever or identity diagnosis. And then on the examination, we just missed the response on the summary of the examination, which would have been there. That's the reason why, even as we were presenting the literature review, there was an emphasis in the picture of it. It's very important to just list it on the summary of the examination.
I think you haven't responded adequately on the important negatives that I had mentioned, why it did not come out on examination, and as well as in the summary. Peradventure, if just ask for a summary, what else we should have considered there? Because you mentioned on your inspection, on examination, that there were no rosy spots, but you decided to omit them in the important negatives in the summary. And then quickly also, you mentioned that this patient, RVD, is unknown. I don't know if I just missed it on your investigations, whether you ordered for HIV test.
Okay, so as I earlier mentioned, on the important negatives, we just missed adding those spots after the examination. And then with the RVD, we couldn't do a test because after we saw the patient, that's why even in our presentation, the patient was just on intravenous fluids as the management that he was being given there. He was moved to a different hospital. before we could have more time with him. So we didn't test for HIV ourselves. We just came with the unknown that we presented.
But don't you think that it was important to do the HIV test?
It is important that we didn't do it because we had limited time with the patient. That's why we missed doing it.
So, thank you very much for that. For those questions, actually, we'll take a lot of them. Thank you.
Thank you so much.
Thank you. Okay. Do we have any other questions in the chat? Do we have any other questions, observations? Okay. Mape, the floor is yours.
Okay, maybe I missed it. My network was quite poor. So I wanted to find out if you maybe talked about any preventions that we can have or that we do currently have on enteric fever, especially the vaccines. Do we have any available, and when are they used, and how are they given if we do have?
Yes. So when we presented the literature review, we talked of the prevention. Among others was education and awareness, and the vaccines were also mentioned. We just did not give examples of the vaccines that we currently use in Zambia. But we talked about the prevention, good hygiene, good food handling was mentioned, but we just didn't add the examples of the vaccines.
So do we have vaccines?
Have you repeat the question?
His mic is not true.
I'm
So I can understand. So we mentioned, so with the vaccines, we mentioned that there are vaccinations that are done. We just also didn't add that one example of a vaccine that we are currently using in Zambia that we came across was the type TCV vaccine. YPBA TCV. That's one of the vaccines that is currently available here in Zambia. It was just not added to the document.
Right, thank you. Any other questions? I see we have Professor Lambert in the room with us. Professor.
Yeah, thank you very much. Engagement on the history, student examination, and investigation. I want us to appreciate the attendance of Professor Kondo. Can we clap for him, please? Professor Kondo, thank you very much for participating. It was fun. He was our Dean of Food Science. And I'm pleading that he should be remaining connected to Dr. Lydia and so that we do grand rounds like you were doing, especially related lending approach with people. I think when we were exactly grand round, Dr. Kondo, it is not people are leaning from all the districts where our physiotherapists are working and also studying and employment. And should Dr. Kondo visit the area, he should let us know in advance so that we prepare for him to give us a motivation of thoughts. So thank you very much, Dr. Kondo. Coming to the, it's a well-covered topic, intensive fever. The way you have done the history, the physical examination, and investigation. Let me just comment on the history. You did very well. There was a chronological order. Presenting symptoms should show progression, the onset of the disease, and how the disease is progressing. Symptoms appear. So that aspect of chronological order, I'm very, very happy with that. That's how we should do. The question you should ask, especially when we suspect fecal oral root type of infection, like you have one sketched, always ask, is there any patient where they are coming from? Community. Is there anybody who's complaining at your family level or community level? You are asking the patient, what do you interact at community level? What this patient is presenting to you? Has she, as he had people presenting with similar symptomatology? That is very important. And you also in the history, I was very, from history alone, you see differential. You talk of malaria or hepatitis. That was the goal. Because to reach a diagnosis, history contributes about 60% of diagnosis when you do a good history. So please, you maintain that. But when you have done this differential, when you are examining the patient, you should try to aim at what you have diagnosed and also eliminate the investigation. That's what someone say positive and the positive is negative. I mean the negative are also important, especially done in differential. So which points in the history will try to explain malaria or which ones are going to be positive for intensive fever? I think it was someone who was asking about coding. Please let's study something how to go in detail talking about the history. On examination of very hard. Vital signs came out. Well, the temperature was 38. And what was also happy is when I heard you say, we listen with your stethoscope and listen to the first heart sound and the second heart sound. In other words, systolic pain, isn't it? Very important. Did you try to listen to the murmurs between first heart sound and second heart sound? If you are trying to listen, was there a soft systolic murmur, for example? This patient has a tachycardia, so to speak. Did you listen and try to listen? You are letting yourself, your ears, to listen what is happening to the heart. But another point you should always say, you also listen to the diastolic pain. From second heart sound back to first heart sound. Because sometimes the murmurs do appear or you are heard in the diastolic phase. I always want you to be clear on that. Then when you talked about the possibility of using a Glasgow Coma scale assessment, you already talked about orientation. When you are touching Glasgow Coma scale, just mention the patient was open eyed spontaneously. And orientation in the person, space, and time. We have done orientation, which means fully oriented. Very important. Let's say patient was obeying the instruction as we are examining. So you have done all the three areas of Glasgow Coma scale. Please master that one. If you are going to relate the patient to Glasgow Coma scale, very important. And about the history of jaundice. History of jaundice. When examining, was about one of the top ones you are looking for. Is there jaundice in this patient? Because it came out in the history. You understand? Under the history that the patient was not producing urine, was not passing urine. Now, we also say that the patient said he never experienced distended blood in the history. So when examining, the liver affect the suprapubic area and say there was no palpable blood. If there was no palpable blood, what reduced the urinary output? You should emphasize on dehydrated spinal. Because this patient was vomiting and was diarrhea. And also diarrhea, patient told you at the beginning it was yellowish, you brought it out. There is so blood in the diarrhea. So check for anemia in a panel. Make sure it goes, because it is in your head. You are trying to justify when you pick out in the history when you are doing the examination. And for your stage, even your stage, inspection, palpation, percussion, or spontation. Always think of that. Go step by step. We miss out if you are talking about it, what should come with the inspection, you are talking with under palpation or spontation, don't mix. Go point by point. On inspection, on palpation, did you get any tenderness, for example? Did you palpate any mass? You suspected hepatitis. Did you look for enlarged liver? And you did mention that also look for enlarged spleen. That was very good. Now, when you are palpating for spleen, don't forget to mention the notches. Because the notches on the spleen will help you on the palpation to say yes. In the left hypochondrium, I'm palpating a mass, and I think it's a spleen. I'm palpating the notches. So please be thorough as you examine the patient. Remember, look for systemic inflammatory response feature, So look at the respiratory rate, heart rate, temperature. Is it hypo or hyper? You relate that. Because this patient was shown signs of toxicity. Now, look at the disease. This disease, where is the mucosa? What is the pain? Is the visceral pain? Okay? What if the infection is going through the wall of the intestine and to reach the serosal cover, or even it perforates, the disease presentation now and even the physical finding could be different. If there is perforation, what will happen? There will be either local peritonitis or generalized fecal peritonitis, depending on which side. Sometimes in the area of ileocecal, that which may perforate, that will be fecal peritonitis. So those are the things you have in your mind. It's a very difficult condition, and always you tend. I worked at a lady, and it's always like that. From intendere, you study infection. So be careful on that. When you came to diagnose investigation, I was happy because you tried to say we start with diagnostic investigation. Even when you are presenting a long case, jump for diagnostic investigation. Your examiners will know that you know what you're talking about. If it is not talking about investigation standard, no. Look for investigation which will give you a diagnosis. So I think that was good. On the examination, on the treatment, you measure very well clinical treatment before you get culture and sensitivity, or you try to use it broad spectrum antibiotics. So wherever we go, related to the laboratory, go there and say, what are the common you can abdominal, acute abdominal, like Enteric paper, which are the common findings in terms of culture and sensitivity. This culture and sensitivity reports will vary from hospital to hospital, because it's a hospital environment we are talking about, and the community that is using the hospital. So please be interactive, learn to interact with this department, like the laboratory. Cultural sensitivity should be knowing which is a common one when you're waiting. Otherwise, I'm very happy, well organized, and I like the introduction. I'm a fifth year. I'm seventh year. That is very good. Fifth years, we work hard on a history take to be perfect. Physical examination. To perfect. Then senior, they will do examination, but investigations and how to manage patients. I must salute Dr. Mpisa, the head of internal medicine in our university. You can see he's guiding you how to become a good practitioner in practice. Now, when you qualify, if you go to a hospital where there's intense fever, you are seeing it more often. What will be your approach? How will you save the population from further infection? Don't sit at the hospital and wait for patients. Prevention is better and cheaper than cure. You need to control the cost of running your hospital. So if you are running your hospital and you know the cost, prevent that disease to spread out there. Run into precautionary measures. This is people all. So we quickly start telling people, there's now a fever in the community. Boil the water, eat hot food, not cold food. Contaminated water, you have a problem. You're trying to control the cost of running your institution. Prepare ahead. You must be effective, cost-effective practitioner wherever you be. Save as many lives as you can and encourage early diagnosis, early treatment, prevent complications. And you discharge your patients early if you have not already. If you have perforated your core surgeons now, laparatory, and regulate protecting it apart. From the calcium here up to the pubis, big incision, room for perforation. And one of the investigations you could have mentioned in the case of perforation is an X-ray chest, which you show in the diagram. If there's a perforation in the bowel, there will be gas under the right diaphragm. Don't look for gas under the left diaphragm. Dr. Philip here, what the diaphragm, there will be fundus to the stomach, which is always having gas. So the gas you are looking for is under the right diaphragm. If you see gas there, there's a perforation somewhere which has leaked gas collecting under the diaphragm. So be holistic, be ready to practice with all the knowledge that you need. So I salute the moderator for this topic, and also Dr. Phyllis here, and all the deans who are participating. This is the way we should drive, and also connections from abroad. In this case, our home. On Tuesday, on Monday, we have a connection from Australia by pre-made grant round. And medical students, please try to listen to Monday training. Listen how your juniors are doing. Tuesdays, pre-clinical anatomy, physiology, being discussed, topics. And Wednesday is the research. Thursday is your area, ABCSP. Friday, there's the health sciences, nursing, physiotherapy. Try to find the time to listen because we learn together, to work together. Make a working team wherever you are. Everybody is important, including cleaners. Engage them what they want to know from you as you work. Why do they clean? To avoid hospital infection. Things like that. So please become good practitioners. And you start now in the clinical period of training. Thank you.
Excellent. Thank you, Professor Lambert. I see we have our Dean Dr. Piri in the house? Dr. Piri, do we have any words?
Yeah, I'll be good by the Philadelphia. It was well researched and done, and Dr. Pisa, I think, guided the students very well. I want to say one or two things. I don't think I want to repeat what has been said by the prof. It was good that the summary had a, a diagnosis and differentials, and they also at the end of at the end of each information, there was also another set of differential diagnosis. What I want to say is that during the investigations, each of the differential diagnoses should have some investigation mentioned to rule out one if all differential diagnoses were eventually ruled out. So if you mention that a differential diagnosis is such and such a disease, make sure there's an investigation which actually rules out, not just mention and then nothing is mentioned. For example, should have said, I know that there was the question of renal injury. There should have been a set of renal function investigations which stated how far that renal injury widely the tendency diagnosis. So investigations must marry the clinical impression and the differential diagnosis. So you must answer the question, why do you rule out this and that and the other and so on? So those must be mentioned. And when you're doing an abdominal examination, make sure you do a hysterectomy examination as well. I think I'll end there for the time being. Thank you very much. Thank you.
Thank you, Dr. Piri. All right. If we don't have any other questions or observations, I would now like to invite closing remarks, starting with our presenters team. The floor is yours.
So, good afternoon once again. Emmanuel and on behalf of my fellow presenters, would like to express our heartfelt gratitude for everyone for being here. First and foremost, would like to sincerely thank the professorial team. Your guidance throughout our medical journey, starting from even just when we came as first years, has been very helpful. And we know that it will be even outside these walls. And we're very honored to have been privileged to present this case in your presence. Appreciation also goes to the deans present. Would also like to take a moment to appreciate the incredible experience that we had with our moderator, which guided us a lot throughout everything. Our head of department, Dr. Pisa, who's always there for us here on campus, at the hospitals. Would also like to appreciate the presenters, my fellow presenters. Thank you. The preparations were very much intact as group work, and our dedication to timekeeping process at least helped make the presentation possible. Our audience, thank you so much for attending, and this should continue because it's a very vital program that helps us in not only fostering ongoing education and professional development, but also builds even more excellence in clinical care through these discussions that we have, because we tend to learn a lot in and outside of these walls. We'd also love to lastly extend our sincere appreciation to the organizers, including the IT, for the work coordination and technical support that also was part of what made this presentation here today possible. Thank you very much.
Thank you. Job well done. I would now like to invite our moderator, Dr. Mpisa, to the floor.
Thank you so much, Madam Shinond. I just want to thank everyone who attended. I also want to say a big congratulations to the students. Job well done. Also, thank you, professorial team, for the advice rendered to us also. We are learning every day. Thank you so much. I would want to say goodbye.
Thank you, Dr. Mpisa. I would like to invite from our professorial team, Professor Lambert, to give his closing remarks.
For as usual, on behalf of the Vice Chancellor, Professor Nyeresani, and the CEO, Professor Peter Mao, top physician, and they think he should be teaching you also. So, and on behalf of Professor John Denda, the Director of Medical Education, and my colleague, Professor Mlenga, who is the Deputy Vice Chancellor in Innovation and Research, I say thank you very much indeed, the Dean. Now the Dean of Internal Medicine has done it. Next week, another department should do it, isn't it? Well, internal medicine has done today, then in future, surgery, obstetrics, gynae, pediatrics, they should be rotating that. Because this is the most important. You see, so I think that's organization. But then you are here, make sure every Thursday you have a case to present. This is the way we interact with our students. This is the way students are interacting with each other. Did you inform Kitwe, Kawe, Logi, you teach? You all have the communication system through your partners or direct. Encourage the entire team to participate. I forgot one thing. After this presentation, Dr. Pisa should prepare 4 MCQ questions and 2 short answer questions, and become masters of intelligent people. Those who want to learn more, they can learn from, especially the literature. Oh my God, very good. Can we learn from the literature? That's what truly you can read each other on intelligent, and you are a team. Don't hide this knowledge. Let a lot of other students in your faculty, learn more. Even the juniors should be seeing what they're doing. So with these remarks, I say congratulations. Be very happy. Thank you.
Excellent. Thank you, Professor Lambert. Once again, job well done, presenters. This has been quite an interesting presentation. Please do not forget, at the end of this, please make your way outside to capture your group photo with our professorial team. With that, we've come to the end of today's virtual clinical educational grand round, held every Thursday. However, every day of the week has its own theme. Monday is preclinical. Monday is pre-medical. Tuesday is preclinical. Wednesday is research. Thursday is grand round. These are presentations from the wards that our 5th and 7th year students present on. And Fridays are for our other respective faculties, ranging from health sciences, nursing, pharmacy, and more. Thank you for those of you who are in attendance, and especially those of you who interacted. With that, please enjoy the rest of your day. Thank you.